It's a great honor and special pleasure for me to present this talk on training of a thyroid surgeon, which to me is probably the most important concept in the management of endocrine surgery. And I must give credit to many programs in India who have developed endocrine training. I would like to bring greetings right at the outset from Memorial Sloan Kettering Cancer Center. This is our new outpatient surgical unit, a state-of-the-art facility. I would also like to bring greetings from New York City. Things change after 9/11, but we have come back to almost normal life. This is the new Freedom Tower, and you happen to be in New York, please do visit. The observatory is outstanding. You will just love this place. So I always like to show some of my aphorisms, which are very popular. Only 20% of you will remember 20% of what I said 20 minutes after my lecture. So the memory span is very small. So we're going to forget everything what we said tomorrow morning. And that's why the meeting is generally 3 days meeting. On the third day, you forget what was said on the first day. So the issue is why we discuss the training of a thyroid surgeon. And there are many reasons behind it. Clearly, the endocrine surgery has become a mainstay of specialty in the general surgery. And the reason is there is a higher incidence of thyroid cancer. In the United States, we almost perform 200,000 thyroidectomies every year. The biology of thyroid cancer is much different than other human cancers. This is not a pancreatic cancer. This is not a brain tumor. I call this a friendly enemy. And that's very interesting to concept that the biology of thyroid cancer is much different. At the same time, even though it is a friendly enemy, there are types of enemies who are very aggressive. And our responsibility as a good thyroid surgeon or a well-trained thyroid surgeon is find out who are the patients with thyroid cancer who are likely to get into trouble. There is emerging technology, and I'm sure you're going to hear in the next 2 days about the robotic, the endoscopic, transoral surgery. The one thing I want to bring up right in the beginning, the complications of thyroid surgery, though minimal, they are most serious problem. Just imagine a young girl with permanent hypoparathyroidism or a professor of surgery with vocal cord paralysis. The life changes. Clearly, there is an overdiagnosis and overtreatment. And what is important in the management of thyroid cancer is the first procedure is the most important for cure of the patient. And if you're going to take care of the patient with thyroid cancer, go from A to Z. This is very important. Now, I just want to show you this slide. Many years back, I presented this with a huge thyroid, the airway which is barely 2 or 3 millimeter. And the problem starts in the operating room because the anesthesiologist tells you, be prepared to do tracheostomy. No way, Jose, you can't do tracheostomy. You can intubate this patient very well without any problem. Or a patient presents like this with a large tumor, paralyzed vocal cord. What do? I tell them, go from New York to Lucknow. There is a great endocrine center there, and Dr. Agrawal will take care of you. This is a difficult problem. The chances of this patient's recurrence is very high, local recurrence, nodal recurrence, and distant metastasis. So we have come a long way. We started from Coker's Parker knife to now the robotic surgery. Things have changed quite a bit, and that's why I always like to call from Coker to Chung Wong or from Vienna to Seoul, Korea. Things have changed quite a bit. Now, the trainees of Coker was a great, not only the surgeon, the biologist, but more importantly, a great teacher. He taught several American thyroid surgeons, including Harvey Cushing, William Halstead, William Mayo. And they all became the greatest of the great thyroid surgeons in the world. Now, it will be my responsibility and good opportunity for me to pay tribute to two of the greatest heroes of mine and many endocrine surgeons around the world whom we lost in the last year and a half. One was Blake Cady from Leahy Clinic, and the other was Orlo Clark. Now, keep in mind, the philosophies of these outstanding teachers and surgeons were quite different. One was strong proponent of lobectomy, one was strong proponent of total thyroidectomy. However, what we need to realize, the outcome was the same. The debate in thyroid surgery goes on because the outcome is the same. Now, their contributions are extremely well recognized, and that was through camaraderie, collegiality, respect, and friendship. That is the name of endocrine surgery. And these two giants in thyroid surgery represented their utmost respect to their colleagues, to their passion, to their profession and passion. That is very important. Now, you can't give a talk without showing something from the New York Times. There are two slides you must have, one from New York Times and the other from New England Journal of Medicine. So this was a write-up in 2014, an epidemic of thyroid cancer. Now, why am I showing you this? Not only there was an epidemic, but my name was quoted in that. And you know, there is the greatest joy when your name is seen in New York Times. Now, at that time, or even before that, about 10 years before that, I made this slide. And I called it not epidemic, but I called it pandemic. And truly now we realize that the thyroid cancer is a pandemic of diseases. I always like to show you this slide just to give you the idea how much PubMed literature is available. Now that is perfectly okay. It's the same paper we write again and again. But look at the Google site. There are 647 million sites on thyroid cancer. Now, when we talk about the training of a thyroid surgeon, there are 4 issues I'm going to address. Who should be trained? Who should perform thyroid surgery? Or the simple word, whose domain it is. The next is standardization of the training, both of the surgeon and the fellowship. Impact of technology, that's what I call scalpel to robot. And the most important, responsibilities of the mentors and vision for the future. Where do we see ourselves as a thyroid surgeon and as a mentor in future training thyroid surgeons around the world? Over years, thyroid surgery was dominated by general surgeons. Why? There were territorial disputes, the referral patterns, and most important, there was an underlying issue of finances. The head and neck surgeons, there are 2 groups of surgeons, the head and neck surgeons and the endocrine surgeons. The head and neck surgeons are very well trained in oncologic surgery. Do they understand 100% the biology of thyroid cancer, the ultrasound, etc.? That is something would be trained in near future. Now, keep in mind, in the past, head and neck surgery was also dominated by general surgeons. Over last 25 years, things have changed in United States. Almost 80% of the head and neck surgery is now done by otolaryngologists, and only 20% is done by general surgeons. Now, there are certain critical aspects of thyroid surgical training, complex issues, as I mentioned before, management of recurrence. Anybody can take care of a 2-centimeter thyroid cancer. But the problem comes when there is a recurrent disease in the central compartment adherent to recurrent laryngeal nerve. Complications are very important. Common surgery, but serious complications. And today, the whole panorama of management of thyroid cancer has changed with the understanding of the molecular markers-based treatment or targeted therapies, and more importantly, our major advance that we have made in last 10 years is the understanding of the biology of anaplastic thyroid cancer, the BRAF mutation, and most important, the mutation-based treatment. One of the most disastrous human disease, anaplastic thyroid cancer, where the average survival used to be 3 months, is now extended to 3 to 4 years. And I think this is a major change in the management of thyroid cancer. Remember, good judgment comes from experience, and experience comes from bad judgment. Thyroid cancer is a surgical disease. Myself here and my colleague, endocrinologist, Dr. Tuttle. Now remember, he does not get any complications. The endocrinologists are generally the most aggressive thyroid surgeons in the world because they don't have to look for the nerve or the parathyroid glands. Now let's just go back to the history about the performance of the number of thyroidectomies by general surgery resident. This is one of the landmark paper published in 1995 by J. Harness. The average number of thyroidectomies performed in general surgery training was 12 to 13, miserably small number to train somebody or to be called as a thyroid cancer expert. Things change in 25 years, and now you take a look. This is a paper by Rebecca Sippel, and she showed that bulk of the thyroid surgery is done by otolaryngologists. You can see here, the average experience of a chief resident in ENT was 50 thyroidectomies compared to 20 in general surgery. So why there is a domain issue? As I mentioned before, multiple specialties have interest in thyroid surgery. The general surgery, the otolaryngology, the surgical oncology, head and neck surgery. There is clearly a referral pattern, a referral from general practitioner or the endocrinologist. Experience and expertise is very important. And most important, financial issues, and there is always a prejudice and ego. And this is very important in surgery. Prejudice and ego leads to territorial dispute, financial issues, and animosity. Now, let's look at the thyroid surgery and the training of a thyroid surgeon. It can be the background of general surgery, otolaryngology, even pediatric surgeons, surgical oncologists, and then you have got two major groups, the head and neck surgeons and the endocrine surgeons. Let's analyze each one of them. Otolaryngologists, they have limited experience. They don't have a huge experience. They can do a small thyroidectomy, but when it comes to understanding of the biology, the controversies, and overall management may be very difficult. But remember, they are the main gatekeepers. You go to the otolaryngologist for any head and neck problem, they will examine your thyroid, get an ultrasound, and they are the first line of evaluation of incidentaloma. What about the surgical oncologist? Well trained in surgical oncology, but limited training in head and neck surgery and limited training in thyroid surgery. They do understand the biology of the disease because they put it in the equation of other surgical oncology issues. Now, this is what we wrote once, the PET-associated incidental neoplasm, what we called as pain. They see this very often compared to any other specialty. Let's look at the thyroid surgery as a general surgeon or otolaryngologist. Now, the head and neck surgeon who could be trained from general surgery, which is about 20% now, and otolaryngology, which is about 80%, things may be a little different in India, but this is the practice in the United States now. The head and neck surgeons are quite familiar with the management of the central compartment, the larynx, the trachea, the vocal cords. They can manage the trachea very well, and they do understand the controversies because that's what they have been trained during their fellowship. Let's look at the endocrine surgeon. This is clearly a new specialty, and I'll mention when it started here in the United States. Clearly now it is a recognized specialty. There is a good experience and expertise. They are great teachers, And I showed you the two great teachers, Blake Cady and Orlo Clark. There are limited number of surgeons. Unfortunately, the training programs are producing approximately 30 to 40 endocrine surgeons. They are not very familiar with neck dissection and vocal cord evaluation, and sometimes they will need help for tracheal resection or reconstruction. The Head and Neck Fellowship is well known in the United States for a long time. There were two background societies. The Society of Head and Neck Surgeons, dominated by general surgeons, and American Society for Head and Neck Surgery, dominated by ENT. These were merged together in 1999, and I was very fortunate to be the co-president of the year, in the year it was founded. Currently, there are approximately 42 programs of Head and Neck Fellowship and 52 positions. Out of these, there are 4 dedicated to endocrine surgery. This is through head and neck surgery. Let's look at the different perspective. In this Head and Neck Fellowship, about 40 to 50% of the volume is related to thyroid surgery. The number of thyroidectomies performed in the United States has gone through the roof. And these head and neck surgeons are quite familiar with the neck dissection, tracheal resection, and rarely laryngectomy. Let's look at a different angle now, endocrine fellowship. This was started by American Association of Endocrine Surgeons. The formal endocrine fellowship started in 2005, and the match started in 2007. Today, there are 27 programs training approximately 35 candidates. Now, I must give credit to your group in Lucknow who started MCH endocrine surgery back in 2004. Congratulations to the entire team. You have developed the endocrine program in India, which is much ahead of other programs in the rest of the world. Now, I was asked back in 2001 by John Watkinson from Birmingham, England. He asked me to give a talk on thyroid surgery, the domain of whom, in front of John Fondon and Malcolm Wheeler. And take a look at this statement I made that time. Thyroid surgery is the domain of a well-trained thyroid surgeon, irrespective of the background specialty. It should be the domain of a parent specialty, but the domain of a well-trained surgeon. It should not be the issue of parent specialty. It doesn't matter whether you are a general surgeon, otolaryngologist, pediatric surgeon, as long as you are a well-trained thyroid surgeon, you should be able to master the technique. Now, what is our responsibility in the training program? There has to be a core knowledge, anatomy, pathology, biology. Clinical expertise is undoubtedly very important. Expertise in not only in the surgical technique of thyroidectomy, endocrinology, but the radiology. Understanding of the prognostic factors and risk groups is very important. Judicious application of newer technology, nerve monitor, harmonic, endoscopes, and robotics, very important. And as I mentioned before, understanding and evaluating for adjuvant treatment. The medical oncology has become a sub-specialty in endocrine surgery today or endocrinology today. Do the fellowship in 1 to 2 years, depending upon your research interest. Spend some dedicated time in thyroid surgery. After the fellowship, go around the world, maybe in your own country or different parts of the world, to see the perception of thyroid surgery around the world. You must be expert in ultrasound. You must be expert in ultrasound-guided needle biopsy. And as I mentioned before, understanding of the biology of thyroid cancer. The educational activities are very important for endocrine surgeon. The endocrine conferences, thyroid tumor boards. You should have a mentor both locally, nationally, and internationally, who you can reach out for not only complex problem, but advice and decision making. You must get involved in the clinical and basic science research if you want to be ahead of the game and then the top of the leadership. So let's just summarize. The training of a thyroid surgeon can be through general surgery or otolaryngology. There is a board certification. Then you can do endocrine fellowship, AAES based, like you have one in Lucknow, or the head and neck fellowship, surgical oncology fellowship. And then you can do the international fellowship around the world, depending upon your interest. You can go to South Korea or to Thailand or to Japan. Again, ultrasound, MEVAT, robotic thyroidectomies, these are the nuances in the management of thyroid cancer, and we should be very familiar with that and decide what applies best to your patients and your institution. Now, I'm quite fond of this slide. This is from Jack Lorey, the famous thyroid and head and neck surgeon from Buffalo. He called different terms for the low and high volume surgeons. So he used the word dabbler. Dabbler means superficial care, just doing little bit, not in the depths, not A to Z care, but A to C care. That's not good in the management of thyroid cancer. So he divided the low and high volume surgeon, called them dabblers. Low and high volume institution, called them dabblies. And the complexity of the procedure, low and high complex, that he called as dabblage. I am very happy to see this slide and the wisdom of Jack Lorey. We are always in search of an ideal surgical procedure. We have been doing this since beginning of the last century, since Coker's teachings. Modern technology will turn a third-class surgeon into a second-class one, but will never turn a second-class surgeon into first-class. And our responsibility as an endocrine surgeon is to be the first-class one. New implications of technology, harmonics, nerve monitor, we can go in the details, and I'm sure you're going to talk about this for next 3 days. The robotic surgery, the endoscopic surgery, again, I must go back to the risk group stratification, understanding of the biology, and the implementation along with working relation with the endocrinologist. The most important aspect of endocrine surgery is develop a relation with the ancillary specialties, endocrinology, medical oncology, the pathology. I think these are very, very important ancillary specialties we have to get involved in. Endoscopic surgery, is it minimally invasive or maximally expensive? I will leave it to your best judgment. To be a good endoscopic surgeon, you need to be a better open surgeon. When you see a patient with extremely advanced cancer, where you know the mortality rate is very high, send the patient to a tertiary care center. Send the patient to Lucknow. Don't take care of the patient in a small town because the cancer will haunt you. And this is the classical example. This patient was explored outside New York City, inoperable. We took care of this patient 12 years back and he's still alive and doing very well. And that's why I always say, don't get into the lion's cage if you don't know how to get out of it. That previous tumor was like a lion's cage. And if you know how to take care of the patient, then only jump in this lion's cage. The good physician treats the disease, but the great physician treats the patient who has the disease. And our responsibility in training young attending or young surgeons is to train them to take care of the patient and not the disease itself. The decision is more important than incision. When technology is a master, remember the result may be disaster. And I want to show you this. The endoscopes and robots are only mechanical tools operated by electricity. The fingers are the best tools as they are connected to the brain. And I think that's very, very important message of the training of a thyroid surgeon. Where do we look for the future in thyroid surgery? This was one of the articles published by Jay Harness when he was president of the AAES about the recommendations for future. Develop centers of excellence like one you have in Lucknow, increase efficiency and quality of care. Most important, decrease the cost, reduce the complication rate, and do your own audit. So you learn from your own audit where you stand, where your group stands. What is the fellow's responsibility or the trainee's responsibility? Work hard, be honest. I think the most important aspect of being a fellow, number one, be honest, and number two, have a great attitude. Attitude towards your teachers, towards your patients, towards your family, and towards your work. Enjoy the work and the family, and look at the thyroid surgery as a passion, as a hobby. And then you will have the joy of thyroid surgery. Now, the training of thyroid surgery outside United States is a little different. In Brazil and other parts of the world, still the thyroid surgery is dominated by general surgeons. Things have been changing quite a bit lately. There is a considerable interest from otolaryngology group, both in United States and rest of the world, about thyroid surgery. We need to work with our endocrinologists. And again, as I'm going to say, I said before, develop the centers of excellence and develop a thyroid armamentarium. And this is what I call the endocrine armamentarium, with the center of excellence and all the specialties directly involved in the management of thyroid cancer. When I was president of the American Association of Endocrine Surgeons, we brought in this word with Janice Pasica, and this is what we call kindred spirits. And this is the basics of endocrines. And I call the Endocrine Society the friendliest of the societies. And any new attendee who comes to AAES recognizes in a matter of first 10 minutes that this is the most friendly society. That's how I was greeted in 1986 when I joined the American Association of Endocrine Surgeons by some of the great mentors of thyroid surgery around the world. Now, there is an academic ladder in endocrine surgery. Develop interest in endocrine surgery, do the training, do the fellowship, spend some time learning the basic science, research, and the highlight of the surgical ladder is getting involved in the national, international societies and be the leader in national endocrine societies or international endocrine societies. IAES is one of those, and there are many organizations both in India and Asia. I just want to show you this slide. This is my favorite slide. Training of a thyroid surgeon. Journeying through thyroid career is like driving a car. There are 4 most important rules. Have the self-confidence and self-control. You are in the driving seat of life. Select the route, your goal, your destination. Negotiate the roadworks, the potholes, the obstacles. Look at the other drivers and stay in your own lane. Check the rear view, which is the past. Pay attention to your surrounding, which is the present, and look through the window, that is the future. And then you will enjoy every moment of academic surgical life. And that's the goal of being a thyroid surgeon and training a thyroid surgeon. There are 3 stages in the life of a thyroid surgeon. The first 10 years, you learn how to operate. The next 10 years, you learn when to operate. And the most important, last 10 years, when not to operate. And that's very important. That's where we have multidisciplinary teams and tumor boards. And there is one more step. When to send the patient to Dr. Agrawal, you know that this patient is definitely going to recur. I just want to conclude by this famous statement by William Halsted: the extirpation of thyroid gland typifies, perhaps better than any operation, the supreme triumph of surgeon's art. And that's the message we give in thyroid surgery. It is the supreme triumph of surgeon's art. Thank you very much.